Hey guys. All right. So today we're going to talk about schizophrenia, psychosis, and the neurodevelopmental disorders. So individually, at least as far as these topics go for testing in the course, there's not a huge amount of information for each individual topic that we're going to be going over. That is not to say that there's not a huge amount of information for these topics. The study of schizophrenia spectrum and the neurodevelopmental disorders alone, I mean, that's a lifetime's worth of work and research for a lot of people. And there's entire organizations dedicated strictly to research and trying to find treatments and cures for those issues. So it's not to say that they're small or insignificant or in any way less than the other ones. However, a lot of the information, especially about the schizophrenia spectrum disorders, gets really, really, really technical. And some of it, I feel it gets beyond the scope of what we're doing here with this introduction to abnormal psychology. And the same is true with the neurocognitive and the neurodevelopmental disorders, because we're going to start talking about brain disorders and the plasticity of the brain, and we're getting away from the mind so much, and we're getting to talk about things like genetics and actual brain structures and those things. So it gets super complicated, super quick, and I don't want this to get beyond the introductory level that this class is supposed to be. So, with that being said, we will be mixing the Chapter 13 and Chapter 14 lectures together into one video for this particular presentation. So, schizophrenia. Nowadays, we say that schizophrenia occurs on a spectrum. We refer to it as the schizophrenia spectrum disorders. When something's on a spectrum, that means that there's a whole kind of a whole range of things that can occur with that disorder. We do the same thing with autism. We have the autism spectrum disorders, and there's a wide range of symptoms. They all share kind of a similar overarching set of symptoms, but then there's variances and differences in between. So that is true with schizophrenia. So schizophrenia literally translates into the word disordered thinking or disordered mind. And it has different features. When you open your textbook and you look into schizophrenia, you're going to see just diagnostic after diagnostic after diagnostic of different types of schizophrenia. Schizophrenia with catatonia, schizophrenia with paranoia, schizophrenia with this, schizophrenia with obsessive compulsion, schizophrenia with, and it goes on and on and on and on. The different types of schizophrenia are not necessarily something I need you to focus on so much as I need you to understand what schizophrenia is by itself. So, schizophrenia by itself is a series of delusionary symptoms that occur in the subject's mind. The person believes things that are not true, sees things that are not true, hears things that are not true, and to a lesser degree and with less frequency, sometimes even feels things that are not true. So this disorder is kind of keystoned by the idea that the patient is experiencing thoughts, beliefs, and perceptions that aren't actually there. In its purest base form, the person with schizophrenia will suffer the hearing of voices, and that can be constant, or it can be intermittent. The magnitude of the delusions, and that's what we call the beliefs. Hallucinations are are auditory and visual tricks that happen. Delusions are mental tricks that are happening, belief tricks. So the magnitude or the strength of the delusions can be absolutely impenetrable, to where the person with schizophrenia absolutely 100% believes something that is completely fantasized, and they believe it with all of their heart. And it can actually be kind of more like a minor annoyance. Like, I have this thought that keeps coming into my mind that's telling me that this is true, but I know rationally it's not true, and they have to keep fighting to keep control of what their reality is. The hallucinations, like the auditory hallucinations, and that is the most common one, the hearing of voices or hearing things that aren't there. The auditory hallucinations, again, they occur in levels of magnitude. It can be infrequent, every now and then, during times of stress, when triggers occur, or it can be constant, a constant bombardment. Same thing with the visual hallucinations, a little bit less common than the auditory hallucinations, but it does happen. So you can see how a person with schizophrenia who is in the middle to the higher end of this spectrum would have a very difficult time leading a productive and or healthy life. If you are constantly being bombarded with voices that aren't there, it's not like a person with schizophrenia can just say, oh, that's not real, I'm going to ignore that, because the delusions make them real. Just like we talked about with the somatoform disorders, your mind dictates what's real to the body. If I hook you up to a diode or to an electric machine and activate the pain centers in your brain and tell you that your arm is on fire, it doesn't matter if your arm is really on fire. Your brain thinks your arm is on fire. You're going to experience that pain like your arm was on fire. So when the schizophrenic is hearing the voices, it's not that they're going, oh God, there's that voice again. I need to. For many people on the mid to higher end of that spectrum, it's a real voice. And the problem is the voices are never, they're never telling people, God, you look great today. Good job. You really did a good job in that meeting or anything. They're almost always very negative. They're almost always insulting the person that they're talking to, or encouraging them to do things that they should not do, or things that they personally find terrible or horrible. Remember I told you how the person with obsessive compulsive disorder has these obsessions about thoughts that are intrusive, that they don't want, thoughts like, oh, my family dying in a horrible car crash or something like that. So the auditory hallucinations for the schizophrenic will often tell them things that are terrible to hear. Your kid is dying right now. Your family doesn't love you. You should kill your family. You should just horrible. Think of something terrible. There it is. And these run contrary to what the person actually wants to think about. So it's never something that they think, oh yeah, that's a good idea. They don't receive inspiration from these voices. These voices are like having a constant, terrible, horrible bully in your mind. And sometimes there's one, sometimes there's two, sometimes there's hundreds. So imagine what it would be like to be trying to sit in a meeting and have a crowd of 100 people screaming at you, all telling you what a terrible piece of whatever you are. Or that you should kill yourself, or you should, you're worthless. It just and constant, going on for hours and hours at a time. Combine these with any visual hallucinations this person may be having, that, where they see things that aren't accurate. It can be, and again, it's always terrible. It's always nightmarish. It's never something pleasant or good, or insightful. Picture whatever horror movie you want to imagine. Picture that is happening in front of you while you're hearing the voices. And then there's the delusions that can go along with it, which make it hard for the person with schizophrenia to separate the fact that these are hallucinations from these are real. Those delusions can take very specific forms. I mentioned in the last lecture that paranoid personality disorder is correlated with schizophrenia. And I told you already, I don't need you to know all the different flavors of schizophrenia, but just by way of example, one of the diagnostic classifications of schizophrenia is what we call paranoid schizophrenia or schizophrenia with paranoid delusions. So in this case, the delusions are specifically paranoid. So it's not just random horrible delusions about, spiders and then monsters and whatever else. Now the delusions have a specific theme to them. The people are trying to poison me. My food is poison. People want to kill me. Everybody wants me dead. The TV, there's a monster in my TV and it wants me dead, and I have to do something about this. Those delusions, when they take hold, are very compelling to the patient, and so you mix those delusions with hallucinations, and what you basically got is a person who's living in an altered state of reality, and it's never a good state of reality. So paranoid delusions are very common. There's also a type of schizophrenia out there. We used to call it catatonia. Now it's schizophrenia with catatonic tendencies, where the person is schizophrenic. All those things that I mentioned occur, but they also go into statue mode and they just lock into a position. And it's not like they slump down. Like they'll sometimes be in really uncomfortable positions and they'll hold it for hours. And they just lock. They don't move. They don't breathe. Well, they breathe, but they move. They don't blink. They don't do anything. They just go become a statue. And that's it's interesting because that doesn't seem to most people when you're first starting to learn out about it to go along with the whole schizophrenia symptom set. So there are, I was going through your book. There's dozens and dozens that they even list in the book. I don't need you to know all those. What I do need you to understand is what schizophrenia is. Schizophrenia usually has its onset in young adulthood, so right around college age in the 20s. And there is some research that suggests that there may be genetic factors into why it has why it onsets, combined with environmental factors. So you can't traumatize somebody into becoming schizophrenic. That's not how that works. You don't expose them to enough fear, torture, terror, pain, or whatever, or neglect or abandonment and cause schizophrenia. However, people may have this sort of genetic time bomb in them that is kind of predisposed to go off and develop into schizophrenia. And then those types of triggers that I was mentioning before may actually be what set it off. So if you don't have the genetic predisposition, it's not going to happen, we think. And I'm saying we think because, to be honest with you, there's still a lot we don't understand about schizophrenia. We know it's not behavioral. There's behavioral aspects to it, and we can try and counsel and teach mindfulness and teach how to work through that. But for the most part, schizophrenia needs to be treated with medication. And the good news is it can be, in most cases. It can be, the symptoms can be controlled, but treating schizophrenia is about symptom control right now, not about eliminating the disorder. One of the most heartbreaking things about schizophrenia is when it onsets. It usually onsets at in the late teens, early 20s. So right about college age, right? And just speaking from personal experience, I had a friend, and she was her goal was to become a PhD in history. She loved history. She worked in bookstores. She was an incredibly intelligent and very academic young lady who, when she was 21 in the bookstore she was in, she had a schizophrenic break, or her first schizophrenic episode, and the delusions and the hallucinations started. And because of that, it impaired her ability to continue pursuing the education that she wanted to. It impaired her ability to even go to school because the stress of school would trigger the episodes for her. We talk about triggering the episodes. Again, like I said, for some people it's just constant. For other people, they seem to be able to be triggered by stress or fear or those sorts of things. And still other people, when we see them having recurrent episodes, it's because they don't like taking their medication. And that's one of the huge problems with treatment of schizophrenia is in many cases the cure is worse than the disease almost. The medications that we have for schizophrenia are harsh. They are not easy to live with. The side effects of these medications are not easy to live with. We talked about just antidepressants can affect your sexual functioning. The medications, the antipsychotics we give people for schizophrenia, they can make it hard to live a normal life. And I've talked to people with the disorder before, and they say, you feel like you're trading one condition for another. I was schizophrenic, and now I'm almost, I'm like schizoid. I have no affect. I have no emotions. I have no ability to emote. I can't feel anything. So, can somebody with on the schizophrenic spectrum be successful? Absolutely. There's been cases of it happening. And there's probably more cases than just the famous cases we know of. I mentioned in my last lecture the character Russell Crowe played in A Beautiful Mind, a very famous case of a paranoid schizophrenic who was also a brilliant scientist and mathematician. Can it happen? Yes. And there are people out there living with schizophrenia right now, and I've had them in my classes, and I both as fellow students and as my own students. I've worked alongside people with it, so you can lead a normal life. It's not like you are, once you've been diagnosed with this on the spectrum, your life is over. That's not the case, but it is necessary to understand what it is that you're dealing with and deal with those challenges. It's not something you can just ignore, because it is something that can get worse over time if you don't treat it and don't pay attention to it. So at its worst, it is an incredibly tragic and debilitating disorder, and at its best, it is still an incredibly debilitating disorder, but that can be learned to live with like any other disability. So, unfortunately, the prognosis for schizophrenia right now is not great. We don't have a huge amount of treatment that people are willing to engage in. When you see somebody who is homeless, walking around the street, swatting at things that aren't there, screaming at nothing, a lot of people immediately go, "Oh, the guy must be a drug addict. That's why he's homeless." In many cases, since the mid 80s, when there was kind of a national push to open up the mental institution facilities and release people, in many cases, these are people with severe mental illnesses like schizophrenia that have nowhere to go, that have no resources available to them. Treating schizophrenia requires some heavy duty medical and psychological and psychiatric know-how. And if you happen to be somebody who's indigent, has no resources, and has no access to healthcare, yeah, it's pretty easy to see how you could end up on the street with no home, no ability to hold a job, no ability to people being afraid of you at all times and stuff, because so definitely something worth devoting time, research, and energy to, and trying to help people. But as far as schizophrenia goes, that's pretty much all we're going to. Oh, wait, sorry. There's one more thing. Attenuated psychosis syndrome. Okay, so this is kind of controversial right now. It's very controversial right now. So there's a group of people that want to add to the schizophrenia spectrum a thing called attenuated psychosis syndrome, which is basically like schizophrenia light. It's like mild, all the symptoms are kind of mild, and the person is still able to function and live with it, but they still have schizophrenic symptoms. And they want to give it its own name as its own disorder, and instead of just labeling people as schizophrenic, then they're this, and then if the symptoms get worse, then they become schizophrenic. And there's pushback for this. They're like, why do we need this? We have schizophrenia spectrum. This person's on the low end of the spectrum. We did the exact opposite with autism and Asperger's a little while ago. We had Asperger's, we had autism, and now we've eliminated Asperger's, and we just spread the autism spectrum out and said Asperger's, what was Asperger's is just high functioning autism. Well, they're trying to do the exact opposite with schizophrenia and say, okay, well, we have the spectrum, but now we want to add this block down here that's its own special disorder. I frankly don't have an opinion on it. And I asked you to address it. You can read more about it in your textbook, but just so you know, if you do hear or see something called attenuated psychosis disorder, what we're talking about is a disorder where the schizophrenic symptoms are present, maybe not all the symptoms, or maybe they're present, but they're very light, or they're very sporadic, or they're very infrequent. So, speaking of psychosis, what is psychosis? Well, schizophrenia is a type of psychosis. To be psychotic is in psychosis. It's not the same thing as psychopath. And then this gets confused a lot. A psychopath is it's a different classification of person. Psychosis is a mental state where you break with reality. So you can see why that would apply to schizophrenia, right? When you break and cannot comprehend reality versus fantasy or delusion, we call that being in a psychotic state. When somebody enters a psychotic state, their beliefs are not attached to reality. Their perceptions are not attached to reality. So schizophrenia is a psychotic disorder because it is one that pulls you literally out of reality and deposits you firmly in this delusional state. Now, other psychological disorders can become psychotic. Okay, you can have narcissism with psychotic tendencies. You can have antisocial personality disorder with psychotic tendencies. You can have these things. If the narcissism is so bad that you don't just believe you're special, but you actually believe you're Jesus Christ, okay, that would be psychotic. So when you're gaslighting somebody as a narcissist, and you're not just trying to make them feel like it's their fault, but you actually believe it's, that's getting towards the psychotic. So that's what psychosis is. And schizophrenia is one of the psychotic disorders. So moving on to chapter 14, neurodevelopmental disorders. Neuro meaning of the nerves in the brain, developmental meaning at birth and through the developmental process. I'm not talking about the stuff that happens in adulthood and later life. I'm talking about stuff you're either born with or that emerges in childhood, okay? So probably the biggest neurodevelopmental disorder that everyone knows about is ADHD. Right? Attention deficit hyperactivity disorder. And I'm betting in my class now, I've probably got about 30 of you in here. I'm betting there's at least 5 of you that have this diagnosis. The diagnosis of ADHD right now is under a lot of scrutiny because globally, ADHD accounts for about 9% of the population. Okay, that's the whole wide world. But here in the United States, we diagnose it in about 11% of the population. And we diagnose it more here than anyone does anywhere else. And ADHD, if you read over the diagnostic criteria in your book, the definitions that go into determining if somebody has ADHD are really easy to misinterpret. And the reason I'm saying that is we have to remember that any disorder is a clinical impairment of your life, okay? It has to be clinically impairing your life. And the criterion for ADHD is an inability to focus, an inability to pay attention, starting but not finishing multiple projects. The symptoms of ADHD are actually pretty well understood, but it's the magnitude of those symptoms that a lot of people don't understand. Just because somebody is bored and doesn't want to pay attention to something doesn't necessarily mean they have a clinical disorder. Because a little boy has problems paying attention in math class and would rather be outside playing football or soccer doesn't necessarily mean he has ADHD. It might just mean that he's a little boy and he wants to go play football. But on the other hand, they might, and there's also a push out there that says that, hey, the disorder is really underdiagnosed. That a lot of these kids that have fallen by the wayside educationally had ADHD, and we're not properly approaching them. Well, here's the thing. Traditionally, the treatment for ADHD has been medication, and when you start giving psych medication to children, and you start giving medication that works on how the neurochemicals in the brain function on a brain that's not yet fully developed, you're playing Russian roulette. You're gambling, right, with how that person is going to end up developing. And there's a large body of researchers out there that think our approach to ADHD is not necessarily the way it should be. That maybe we went a little too far in the overdiagnosis direction. I know there's a lot of researchers out there that think we haven't gone far enough. That think that these people who are being labeled with personality disorders or behavioral problems as kids or getting in trouble just have ADHD. So it's it is a conundrum because I know I was a hyperactive little kid. You know, I didn't want to sit still in school. I wanted to go out and play. But did I have ADHD? Well, nobody ever said I did. And as it turns out, by the time I got to college, I was able to focus and, you know, go on and do doctoral studies and stuff. So I don't know. That's just me. We do know that ADHD is real. I mean, there are while those cases that I'm talking about, maybe there's a coin toss. There are people who clinically suffer, or not necessarily suffer. I'm not supposed to say suffer, but clinically deal with attention deficit hyperactivity disorder, and it presents itself in a very clinical way in their life. When we talk about an inability to focus, I mean literally an inability to stay focused on something for a decent period of time. When I talk about an inability to finish projects, you know, we're talking about a mind that will not stay in place. And this also comes with features like insomnia and some other things. So people with ADHD, the diagnosis cannot be due to any other psychological issue going on. It can be due to oppositional defiance disorder. It can be due to any behavioral disorders. It can be due to any personality disorders. It can be due to any type of neurodevelopmental problem like you know, any type of brain deformation or anything. But it must be clinically or imperative that it actually impairs that person's life. So you can read up more on ADHD and how we've gone about diagnosing it. And even the book addresses the fact that maybe we have overdiagnosed it a little bit. What I really want to talk about, though, is autism spectrum disorder. So this is huge, and there's a ton of research going on out there, and it's such a big topic because people on the autism spectrum are part of a growing number of humans in the United States and worldwide. More people are born on the autism spectrum than were before, or at least we believe they are. At least we're identifying them more than we were before. And so there's a big question out there of what's causing this. Why is this happening? You know, we've all heard all the different, you know, it's the TV, it's vaccines, it's this, it's that. Well, you know, no, because as near as we can tell, it's something that's neurodevelopmental. It's not behavioral. Autism spectrum, just like schizophrenia spectrum, just like any of the other disorders that occur on a spectrum, can be very, very impairing, or it can be inconvenient. It just depends where you fall at on the spectrum. We used to call that lower end Asperger's. We don't say that now. We just place people on the spectrum and where they're at. So persons with autism spectrum disorder have at some level a diminished social reactivity. remember we talked about some of the personality disorders where people can't interpret what emotions are being conveyed to them. They have the inability to see emotions on people's face. They have the inability to empathize with those emotions. They don't necessarily want to hurt people's feelings. They just don't understand how to interpret feelings. And then very often the person with autism will take it a step farther, and they will express their feelings in ways that are socially inappropriate for a situation. So maybe laughing at a funeral, or applauding when applause is not socially appropriate. Those kind of things. So we see people with autism spectrum disorder having a diminished ability to interpret emotions and a diminished ability to emote properly. Repetitive motor movements. These tics that we may have seen in people with autism spectrum disorder, they're not involuntary muscular tics like in Parkinson's disease, where the person may have twitches or cramps or something like that. That's not what we're talking about. The repetitive motor movements are not necessarily involuntary for the person with autism spectrum disorder, and we believe that they may actually be a calming thing. One of the most common ones, and you may have seen it or heard it, is rocking back and forth to self-soothe. Sometimes it's a verbal tic. The person will click or make sounds. Sometimes they do something with their hands, or they'll pat a desk, or they'll pat themselves. Sometimes it's very disruptive to the persons around them, and sometimes it's almost imperceptible. It just depends on where you're at on the spectrum. But that kind of repetitive motor movement, especially during times of stress, when the person with autism is stressed out, you'll see that type of self-soothing repetitive behavior come out. Inflexibility to change. The person with autism does not like things to be different. And that can be as simple as we have to go to a different gas station because the one we're at is closed, or I couldn't buy the milk in the pink carton. I had to buy a different brand of milk, or this paper that I'm using is a different texture than another paper. A person with autism does not like change. They do not like things to be different. This person thrives on structure. They actually do very, very well in educational programs with structures, calendars, times, appointments, those sorts of things. People with autism do not like it when you tell somebody with autism, "Hey, sorry, I can't make it today. I'm going to be late." That doesn't compute. That doesn't work. I know I can't make it today because I was involved in a terrible auto accident. Depending where they're at on the disorder, they may be able to process that, or they may not. So inflexibility to change is a huge part of it. And again, I refer to this character a lot, but the Dr. Sheldon Cooper on The Big Bang Theory, he also displays a lot of characteristics of somebody with autism spectrum disorder. Inflexibility to change, his absolute need for structure and timing, that kind of stuff. Fixation on specific items or activity. The person with autism will very often become hyper fixated on something. It could be doing something, could be playing the piano, could be drawing, it could be an object, it could be a stuffed animal, it could be a toy, it could be a person. But they will very often become hyper fixated on something, and this fixation will become very impairing to their ability to function, because you can't have something all the time, every time, right? And it'll become the only thing they want to do. It'll become the only thing they want to deal with, to the point of sacrificing eating, to the point of sacrificing any type of social relationship or whatever. They'll become obsessed with something, and losing that thing, whatever that thing is, if it's a toy or something, can be absolutely devastating to this person. So that goes along with the inflexibility to change too. And then again, all of this has a clinically significant impairment, right? again, autism occurs on a spectrum, and for lack of a better term, sometimes it can be very mild. Is that a good word for it? A person can be a little bit autistic, where they have some of the stuff, but they recognize it and they are working with it, and they work with their people and their doctors and their teachers and stuff to work around it. And there's a lot of people who are on the spectrum who are successful and doing wonderful in life. It's just part of who they are, and they have to deal with it. And then there's other people where it's extremely, extremely debilitating. And one of the big challenges when you're dealing with autism spectrum disorder is the families and the caregivers, because it takes a very special parent, brother, sister, teacher to properly care for and respect and help a person with autism spectrum disorder, especially the serious levels, because it can be very frustrating to somebody who does not perceive the world that way, to have somebody flip out and start screaming and breaking things and throwing things just because we have to go to a different gas station. It's people, parents and such who have autistic family members, you'll notice that they tend to kind of be part of a club. They have have their bumper stickers, and they have their support groups and stuff. And there's a reason for that, because as an autism care provider, folks can get care provider fatigue really, really quick. And there's a lot of guilt and stuff that comes with it, but that's a whole different set of disorders to talk about. So there you have it. A really brief look at schizophrenia, psychosis, and the neurodevelopmental disorders. All right, guys.